So, yep, that's it. So that case number 2 is about a gentleman, 71-year-old, active guy, you know, walking, gardening. He's got HTO on the left knee in 2003, then a total knee in 2015. That's for the left knee. He had also a right total knee in 2016. So he has 2 total knees. But this gentleman has a very severe medical condition. He's got cardiac issues, pacemaker, anticoagulation drug, diabetes, and he had some ischemic cerebrovascular accident. Let's talk about the left knee. It's been okay for 3 years, but then it's been really painful for the last 3 months. No history of trauma or injection. Now he has pain day and night, exacerbated with white bearing. He's limping, falls down, and you really cannot stay in that situation. You can see the X-ray here. So his BMI is okay. Remember, he has a history of HTO, so he has 2 scars, one anterior, one lateral. The skin here is very fragile and thin. He's got swelling. The knee is warm and hyperalgesic. Range of motion is not too bad, 105 degrees of flexion. It's got no laxity, and the extensor mechanism is okay. So the first question is for Sam. Sam, you have the history of this gentleman, you know, with his left knee, you know, he also has a total knee on the right knee, but with no symptoms. And the question is, do you need additional examination? You have several options here. Lab tests, joint aspiration of the left knee, joint aspiration of both knees, or would you do an arthroscopy to get some samples and biopsies or other IDs?
Thanks, Seb. So interesting case and poor chap. So definitely some further examinations are required. So physical examination, he's got an effusion in the left knee, but the right knee is dry. The right knee is asymptomatic with a full range of motion. The left knee is painful and is stiff, from what I gather. So I would certainly do blood tests, an ESR and a CRP. I would schedule him for a joint aspiration, which I tend to do in the operating theatre on my next list, rather than doing it in the clinic. And we would get a white count on that fluid, as well as microscopy and culture. And I would be guided by that. But, you know, look, this to me looks and smells like an infection. So I'm going to want to be relatively aggressive in my treatment of it. And even if the aspiration comes back as negative, I'd probably get further biopsies in order to confirm a bug before proceeding with the procedure. And the whole time, of course, you need to just have at the back of your mind that this is a frail chap. You don't want to leave the bugs in his knee for too long, and you certainly want to be careful that he doesn't develop sepsis as a result of this probable prosthetic joint infection.
Afraid only the left knee, not the right one?
If the right knee doesn't have an effusion, I wouldn't go aspirating it, is the truth of it. I don't know if others would, but I wouldn't.
Other exam from the faculty? Nico?
Yes,
Philippe? Philippe? Yeah, Philippe?
Yes, I would try to check if there is a reason for general infection too, because this patient was doing very well for 3 years, if I understood correctly, and now suddenly he developed some pain on the left knee, and perhaps there is a reason, some door where the microorganism can come from. For example, the teeth or the colic problem or urinal problem. So I would also try to have a more global approach to try to understand why he get infected, or probably infected.
Okay, Nico?
Yeah, I think in a bilateral knee that you might need to do a blood culture as well. If you know, sometimes it can be bacteremia, is what Philip already mentioned. So that is a good point that we have to do. And then the question now is, when do you aspirate also the other knee, the right knee? It's based on what Sam said. It's usually based on the physical examinations. If there's suspicion, then you do it and aspirations, right? Okay.
I think that if the patient has hip replacement, we will not do an aspiration of the hip replacement if there is no symptoms. So it's an interesting question, but I agree with Sam. If there is no symptom, there is no reason to aspirate.
Yep.
Okay, so we all agree that we need lab tests, aspiration, for sure the left knee, and that at that stage, if we get information from the aspiration, we don't need to go for a scope unless we don't have the answer. So these are the, you can see the numbers. ESR is 35, CRP 48, joint aspiration, torpid color, leukocytes 3,500 with not more than 90% of polynuclear neutrophil, and after 3 days you get staph epi resistant to methicillin and sensitive to rifampin. Regarding the synchronous potential, infection, just to mention this paper, very large, data, 644 patients with an infection of one joint, and an arthroplasty is in at least one other joint. And what they found, and it was quite interesting, in that the incidence of synchronous bone, prosthetic joint infection was 4%, but then in 50% of them, it was asymptomatic. So which means that even if the other knee is asymptomatic, could be infected, and they managed to find some risk factors. And as you mentioned, Nico and Philippe and Sam, also clinical suspicion, is the main factor. But also if you get patients with immune therapy or neoplasia or which are fragile, it might be relevant to aspirate the other knee. But the main criteria is the clinical suspicion. So that's completely correct. Then we mentioned, aspiration, blood culture, but regarding imaging, which kind of other imaging would you usually use for this specific case? And I will ask this question to Philippe.
I will ask for a complete radiological checkup, but I'm not so sure the long leg films are really interesting at this stage. We will focus mainly on the knee. Of course, we can need a long leg films if we consider to reoperate the patient and to remove the implant. So this is different. But in terms of diagnosis, I don't need that. If I want to change the prosthesis, also it could be interesting to have a CT scan in order to check the rotation. But if there is no clinical problem and so on, probably it's not absolutely necessary to have a CT scan. The bone scan is something we use frequently in France and in Europe, and the specialists of the infection like it, but I'm not so sure, and probably Dan can confirm that this is so popular in the US. And I am not certain there is a need also for any MRI with a special software in this situation. So I think that there is probably a simple X-ray and a bone scan. I would obtain the image I need.
Other option from the faculty?
Yeah. Sap?
Nico, then Dan? Yep.
I think a CT scan might be helpful to assess the bone loss and whether it's the implant positioning. And I would like also to do some stress X-ray to look at to assess the laxity.
Good point. Dan?
Yeah, for me, when you draw pure pus out of the knee joint, I'm not sure additional imaging is that helpful for me, particularly when I'm planning a 2-stage in somebody with a chronic infection. We'll deal with the bone loss and the ligament problems down the road when we do the 2nd stage.
That's because you go for 2-stage. So let's keep going. So these are the different options. We discussed that regarding the X-rays, stress X-rays for the laxity, the bone scan, and as Philippe said, it's definitely not standard in most part of the world. And the CT scan could be interesting for a bone loss assessment. So now you have the full picture. And then what do you do with this patient? How would you consider this case? Is very fragile, medical history, is a high-risk patient. He definitely got, a chronic, at least seems to be like a chronic infection of his left knee. And these are the options that I would like you to consider. And I will ask to Dan what would be your option, even if you already answered a little bit to that question?
Yeah, again, we tend to be very set on two-stage revisions in our institution. He's loose, he's chronically infected. I think for sure one's always a good option, but since we're the referral center, they tend to get sent to us rather than the other way around. 2, 3, and 4 I don't think are appropriate here. Again, I think one-stage revision is certainly a viable option here, depending on the organism you culture out. But again, you really need to have an identified organism if you're going to do a one-stage exchange, I think.
Yeah, we all agree that there is not indicated here. Yeah, Mike?
Sebastian, can I just cut in for a sec? Because there's quite a few questions coming through on the Q&A with respect to mobile spacers. And one of the questions is whether or not the mobile spacer can be used as a definitive treatment of this. In other words, to take the implant out and put in a mobile spacer that would hopefully do the job for the patient forever, particularly in a patient like this. So perhaps Dan, because you're a two-stager, maybe you could answer that question for.
So what I will say is that when we do the mobile spacer and the infection is cleared, sometimes it's a long discussion to convince the patient to come back to have the revision put back in. And again, to me, if this is a less healthy patient, it's not unreasonable, again, to try to decrease morbidity and do a single stage in this patient.
Sam?
So I'm just going to play devil's advocate a little bit, if I may. You said straight off the bat that this isn't suitable for a dare. Now, this is a frail gentleman. The history of infection is actually quite short, isn't it? I thought from the history.
Yeah, I mean, he's got pain for 3 months.
He's got pain for 3 months. I'm not sure that his implants are necessarily loose, and you can judge that clinically when you actually open the knee up. He's got a lot of pus in there. He's got a poor cardiac function, and actually perhaps doing a very small procedure with a staph epi that's known to have around a 50% clearance rate from a DARE, with using an antibiotic that might penetrate a biofilm, might actually be what this chap needs to get him better, and not expose him to the extra risks of certainly having staged surgery, 2 big operations. So I don't know, just a thought.
No, it makes sense. We have to consider the medical condition as a key factor. Nico?
Yeah, I have another thought, Sam. If you look at the box, can you go back to the slide?
Sure.
This is a methicillin resistance, which is for the DARE. It's a poor outcome. Can you? Yeah. Resistant methicillin. So I think by this, I'm not agree with the DARE, because the outcome is not that good, because it's a resistant methicillin, one of the bugs.
So that's true for a Staph aureus. I don't know that it's necessarily true for a Staph epi. We'd have to have a discussion with a microbiologist about that, I think.
And so what about the one stage in that case? Because you don't want to consider 2 surgeries, and we know that the bugs is not so easy to treat. Some thoughts? Or you hate it? You hate the idea?
No. I think this is interesting to discuss this, because of course we can be seduced by the fact to do only one stage. But if the one stage failed, it will be a disaster, you understand? So there is pro and cons. And I would say probably I would be more conservative like Dan Washer, because I would be afraid to fail, because for sure, if we fail with the one stage, it will lead to big general complications.
Good point.
Sebastian, there are just a few more Q&As coming in, and I'm having I'm having trouble keeping up with them. Several of them are on DARE, and questions about what is the likelihood of a 2-stage being successful if a DARE fails. And the second question is, when should you DARE, and when should you go ahead and remove the implants either with a 1 or a 2 stage? So perhaps we could put that to the panel. Sam, you were a DARE man. What do you know about the chance of DARE's failure then resulting in success or otherwise of a 2 or 1 stage?
Yeah, that's a really good point, and it's actually probably the major downside of a DARE when it fails. Having said that, you've probably selected out the infections that are easier to treat by that stage. So it's the more difficult to treat infections that may then go on to get treated by a 2-stage, and therefore the failure rate may be greater. So there may be a numbers game there that we're not quite grasping. So I don't think that the association is necessarily true about failed DARE and causing the worse outcome from 2-stage. Look, typically we're talking about acute infections with easy to treat bugs with well-fixed implants. And if we know that if we catch those infections early, then we can preserve the implants that are well-fixed. And that has a reasonably good chance of success with the lowest morbidity to the patient. And so that's the attractiveness. That's not, now we're talking about a DARE, we're not talking about, you know, washing the knee out, we're not talking about arthroscopic surgery, we're talking about a proper debridement of the knee and all the surrounding tissues and an exchange of the mobile parts, changeable parts of the joint replacement. So it is an extensive procedure. It does need long-term antibiotics. We usually combine it with, as I said, an antibiotic that's going to penetrate biofilm. And so it does have a reasonable success rate.
Yeah, Simon Young did look at this on the New Zealand registry, trying to work out whether or not DARE was associated with a greater failure rate. And I think in the New Zealand registry, their data was that it wasn't associated with a greater failure rate if you then failed a DARE and then went on to a 1 or a 2-stage revision series. Sebastian, back to you.
Yeah, that was great discussion, by the way. And just to summarize what we said, you know, regarding the different options, we said that there, you know, if the tibia is loose and it's a chronic infection, even if the guy is at risk, probably not, you know, a high successful rate. And then we have to discuss 1-stage versus 2-stage regarding different factors we mentioned. So the you know, international, you know, consensus meeting recently tried to, you know, document the advantages of 1-stage. We discussed that, decrease the surgical morbidity, earlier functional return for sure. And, you know, the potential indication, you know, so if you have a non-immunocompromised host, no systemic sepsis, minimal bone loss, soft tissue defects, the microbiology is in favor, so it's not a high resistant organism. You manage to isolate the pathogenic organism preoperatively, and you know the sensitivity of the bactericidal treatment, and there was a high consensus that in this case, 1-stage could be, you know, a good option. And on the other hand, the contraindication are, of course, you know, if you have severe damage of soft tissues, if you don't know the bugs, if you have no proper bone stock, or if you have a complex, you know, sinus tract, all these are potential contraindications. But then the question is, how do you manage antibiotic therapy? You go for, you know, 1-stage or 2-stage, but how do you do with the antibiotics? Pre-op, do you use effective antibiotic pre-op? Do you do just standard prophylaxis? Or do you do nothing until the samples are collected? And also post-op, do you do 6 weeks? Do you do 12 weeks? Then oral, or do you do lifelong oral suppression? And I would hand over to Nico for this one.
Thank you. Thank you, Zach.
Let's say we go for 1-stage, so it's clear enough.
Pre-op usually given a prophylactic antibiotic, that is to avoid super infections. And after that, post-op, it has to be multidisciplinary decision. Usually, I took 2 weeks for IV and then total oral for about another 10 weeks. So totally it's about 12 weeks.
So that's exactly what the recommendation. So I think we agree on that we should, you know, avoid super infections, so standard prophylactic, and then the multidisciplinary decision will make the decision on the antibiotics, but usually it's a 12 weeks total, starting IV and then oral. And suppressive antibiotics that in very specific case, like Sam just mentioned, and only if you have active, you know, antibiotics on biofilm, of course.
I have a question for you, Sebastian.
Sure.
You say this is a métier microorganism. Does it change anything in the management, the fact that this microorganism is resistant to the methicillin, and would you?
No, you're right. Yeah, definitely. It's in favor of 2-stage. It's in favor of two-stage if we rely on the criteria. But that's a balance between, you know, the risk of the patient, especially the skin. Will he be able to handle 2 surgeries or not? And then the bugs and the potential failure of 1 stage. That's yeah, you're exactly right. That's where the discussion and where the decision is not easy, and where multidisciplinary discussion and decision is crucial. So not telling this is, you know, right or wrong the decision we took, but we went for 1 stage. The reason were, you know, comorbidities and the fact that we know the organism. We went for the antibiotic therapy, you know, discussed with the ID specialist, and you know, eventually it's been successful for 3 years now. So we've been maybe lucky, but that discussion between 1 stage and 2 stage was really meaningful, you know, on this, you know, gentleman with all these medical condition. I think that's important to have the whole picture when we make the decision, and not only to consider the knee, and as we've been discussing on this case. And then, you know, we just a couple of, you know, reference. One excellent from Sam, you know, published in the BGG about, you know, the potential, you know, outcome of 1 stage. And what is very important is to select the right patient. And I'm sure Sam will agree on that. And that common sense is, as always in surgery, crucial when we make the decision. And I will hand over to Miles for the next case.